We can start, sir.
Please start.
Very good evening and welcome everyone. Thanks for finding time and visiting this DigiConnect webinar by Indian Association of Occupational Health Delhi branch. We got two interesting topics. The Indian Clinical Practice Consensus Guidelines for the Management of Head and Neck Cancers by Dr. Naba Kumar Kalita. And we have COVID-19 epidemiological updates by Dr. Rajiv Kumar Jain. Now, may I invite the President of Indian Association of Occupational Health Delhi branch, Dr. Gajendra Kumar, to deliver this welcome address. Over to Dr. Gajendra Kumar, please.
Thank you, Dr. Kumaran. Friends, good evening, everyone. I welcome you all to this webinar of our association. And today's topic is very, very interesting by Dr. Naba Kumar from State Cancer Hospital Institute from Assam. And he shall be deliberating on this management of head and neck cancers. And second topic is from our beloved Dr. Rajiv Kumar Jain, who is Vice President of our association. And he shall be updating about the COVID status in the country and internationally rather. So both the topics are important, and without wasting any time, I welcome you all to this program, and I hand over to Dr. Kumaran for further proceeding into the conference. Thank you.
Yes, sir. Thank you, Doctor. And thanks for those pleasant words of inauguration. Now, may I request Dr. Nabakumar Kalita, who is the fellowship in clinical oncology and consultant oncologist at State Cancer Hospital, Guwahati. He has presented and published 9 scientific papers in national and international journals and conference. He has experience of working in State Cancer Institute, Guwahati, Assam, for more than 5 years. Head and neck cancer, we know India is having plenty of, apart from diabetes, heart disease, and cancer, which is in the leading cause of death. It is right time opportunity for us to listen to Dr. Nabakumar Kalita. Over to Dr. Nabakumar Kalita, please.
Good evening, sir. Hope I am audible.
Yes, sir, you're audible, sir.
Yes, sir. Sir, unfortunately, I am in the hospital for some emergency purpose. So I am in the doctor's room only. So there may be some disturbances in between. So, sir, I sincerely apologize if it happens in between. So, nevertheless, sir, I will continue the discussion. So, first of all, thank you to Dr. Kumaran sir and Gajendra Kumar sir for the kind introduction, and I would like to give my sincere thanks to the organizers for inviting me to talk on this very important topic. So today I shall be deliberating on the Indian Clinical Practice Consensus Guideline for the Management of Head and Neck Cancers. So next slide, please. So content of the topic will be the epidemiology of the head and neck cancer, global guideline, why our patient profiles are different, what is our difference with the Western counterparts, what do the Indian consensus guideline on the management of head and neck cancer recommend, is it different from the Western part, and the concluding remark. Next slide. So this is just a statistical data. We all know that the epidemiology about the head and neck cancer, nothing to say about. So globally, it accounts for 4 to 5% of the all cancer, whereas it is the India, the percentage are really high, 17%. And in some parts of the India, it can be as high as 40%, and especially in the northeast region where I am operating. So here the incidence is very high. And lip and oral cancer, we all know because of the occupational habit. So it constitutes more than 10% of all cancers. So if you can see that global 2018 data, so lip and oral cavity cancer, it is the maximum patient. So it is also not The scenario is not different in here also. So northeastern region, the oral cancer, the percentages are really high, and it's a really a thing of concern for all of us. Next slide. This is all about the NCCN guideline, what it tells about regarding the management of the head and neck cancer, uh, depending upon the HPV virus, positive and negative cancer, what it tells about. Next slide. So this is just a SIOM clinical guideline about the treatment of the head and neck cancer. So it really emphasizes that the most important risk factor continues to be the tobacco, which along with the consumption of alcohol. But the infection of human papilloma virus is key in the origin of some of these tumors. So this concept is also really coming up, and the treatment guidelines are now based on whether the patient is positive or negative. Next slide. This is all about the ASCO clinical practice guideline about the management of neck in the squamous cell carcinoma of the oral cavity or the oropharynx. So about details about the hallmark of the high quality neck dissection, indication of the post-operative radiotherapy, and the indication of the chemotherapy, where we need the combination of treatment like concurrent chemotherapy along with the radiation therapy. So this is all about ASCO practice guidelines. So we all know, and we can go to the website to check. Next slide. So it also introduces the concept that squamous cell carcinoma of the oropharynx is increasing in incidence in recent decade as a result of the HPV infection. It may be the latent infection that is occurring, and it seems to disproportionately affect the younger people. The younger generation of peoples are mostly affected, and majority of the patients are presented with node positivity. So pretty locally advanced cancer, it can present as such. Next slide. This is the first, we can say that in 2017 by our own Govind Babu et al. So this is the oncological gold standards practice. So with what and all about the recommendation of use of the monoclonal antibodies in the management of squamous cell carcinoma of the head and neck. Next slide. So what was the recommendation that the nemotuzumab, which is an anti-EGFR monoclonal antibody, it is a preferred monoclonal antibody in combination with the chemoradiation in locally advanced squamous cell carcinoma of the head and neck region. And either nemotuzumab or cetuximab can be used with the radiation in platinum ineligible patients. So many of the patients can be ineligible for platinum due to some age or some other comorbidities. So depending upon that, in those patients which cannot be given the platinum-based chemotherapy, so those patients can be considered with a monoclonal antibody, either with a nemotuzumab or cetuximab. And toxicity is significantly found to be higher. The skin reaction or the hypomagnesemia, these features are found to be higher in the cetuximab, whereas in the nemotuzumab arm, it is comparedly the skin toxicity is found to be lower, and cetuximab is the preferred monoclonal antibody in the recurrent and metastatic squamous cell carcinoma of the head and neck region. Next slide. This is the journal, which is an important journal published by the Anil De Cruz et al. So it tells about a consensus recommendation of the management of head and neck cancer. The cisplatin, so 30 to 40 mg per meter square, given concurrently with the radiation therapy is recommended an alternative to 100 mg per meter square, especially in the Indian scenario where the comorbidities are really high. So 100 mg per meter square is really toxic to the patient. So the study has found that for a cumulative dose of 200 mg per meter square along with the radiation therapy is sufficient, and it is as compared to the alternative regimen of 100 mg per meter square. Next slide. So talking about the differences, is there any difference in the incidence of head and neck cancer in India compared to the global data? And all the guideline, international guideline, like NCCN, ESMO, or COM or ESCO guideline, is it really applicable in Indian scenario or in Indian patients? So we'll like to see. Next slide. So this is the Indian clinical practice consensus guideline for the head and neck cancer. So next slide. The the background was on the occasion of the World Cancer Day. So a task force was initiated uh, by some leading oncologists all over the India, and in 2018 at Bengaluru. And the multidisciplinary task force comprised of some leading specialists, as I have already mentioned, and it has taken the educational initiative of developing the Indian specific consensus guideline for the management of head and neck cancer, because the process is very much different Western counterparts. So some leading members we all know, no need to introduce themselves. So all the leading oncologists. So it comprises the oncological task force. Next slide. So these are all the guidelines they have formulated for all the management of the head and neck cancer. So we can see in the later slide. Next slide. So this is the grade of recommendation A, B, C, D. So as we all know, and the level of recommendation. The best of the recommendation will just go through. Next slide. So the epidemiology and management of the head and neck cancer, it differs from the country to country, and also in India, the population is really different. So there may be some genetic differences and HPV prevalence, which is found to be higher in the Western countries and found to be lower in Indian population. There may be some etiological differences. There may be some behavioral or occupational differences. There may be delayed diagnosis because most of the patients present with a very advanced, locally advanced head and neck cancer is very much common all over the India. Nutritional status and comorbidities. So we all know the patients. Most of the patients have multiple comorbidities with a poor nutritional status. So the treatment options are very limited. Availability of the updated evidences and the treatment availability, the cost is really an issue. So all this factor comes into play when the treatment of the head and neck cancer, especially for the Indian population, is concerned. Next slide. So what is the genetic differences? So around 30% of the head and neck cancer patient in India and Southeast Asia present with some genetic abnormalities like your HRAS mutation or loss of heterozygosity of the HRAS. There may be NRAS amplification, NMIC amplification, or there may be some genomic aberrations like EGFR, MYC, PIK3CA, CDK, N2A. So there are very much differences, and almost 30% of the patient may present with some genetic abnormalities. Next slide. Regarding the HPV prevalence, we can see that in Western Europe, the prevalence of HPV is almost 21.4%, whereas in India it is 7.1%. So we can know that most of the guidelines are based on the HPV prevalence and HPV positivity. There are many more guidelines and many more treatment available for HPV positive head and neck cancer. But regarding the HPV negativity, so studies, there is limited studies in the Western part. And as far as the RTOZ data, 0522 data in US, the prevalence may be as high as 73%, whereas in India, it can be as low as 11%. So there is very much difference regarding the HPV prevalence in India. Regarding the etiological differences, so about 86.5% are reported to be tobacco users, which is very common in all parts of India, and 23.2% reported to be alcohol user. So what is the effect? So the prevalence of users of smokeless tobacco like Kenny, Zerda, it is as common as 25.9% in India, whereas in the western part of the world it is only 3.6%, whereas the per capita consumption of alcohol, it is the reverse. And types of the oral cavity cancer patients. So we can see that non-tobacco users, uh, regarding the non-tobacco users, the 5-year OS data, the overall survival data is as high as 72%. But if the patient uses both tobacco and alcohol, then the 5-year overall survival data reduces to 29%. Next slide. So there may be delayed diagnosis. We know that about 70 to 80% of the head and neck cancer patient, they present at an advanced age. And here also in this part of the country also, we are seeing lots and lots of patients with locally advanced head and neck cancer presented to our OPD. And we know that and delayed diagnosis, it actually leads to the poor prognosis. You can see that in the stage 1, it can be as high as 100%, whereas in the stage 4 disease, so the 5-year overall survival data is very dismal. It is 42%. So, and in some parts of the world, in some part of India, it can be as low as 29 to 30%. Next slide. So this regarding the nutritional status and comorbidities, most of the patients present with poor nutritional status. This is there's a study. They have found that about 57% of the head and neck cancer patients, they present with some comorbidities, and almost 25 to 50% of the patient is found to be nutritionally compromised. So this poor nutritional status, they affect their physical function, quality of life, and the overall survival. So most of the patient present with poor nutritional status in India. Next slide. To summarize, why the Indian population with the head and neck cancer so poor prognosis, because of the different form of tobacco sowing, it is very much prevalent all over in each part of the country. Late diagnosis, most of the patient present at an advanced stage. SPB negativity, the prevalence is very much low in India, and required escalation of the treatment. So these factors are very much different, and they make a compelling reason for our head and neck cancer patient to need treatment specific to their profile, not according to Western guideline. Next slide. So this is just a summary of the consensus that is achieved for the management of oral cavity cancer, whereas it's a localized disease, the option can be surgery or for conventional RT, whereas in the locally advanced or oral cavity cancer, there can be an option of neoadjuvant chemotherapy if it is a surgically unresectable and followed by either by the chemoradiation or single RT, and also there can be option of the surgery and followed by the presence of advanced fissures. The patient can be a candidate of RT along with the concurrent chemotherapy. Next slide. So regarding the hypopharyngeal cancer, so localized disease, definitive RT is one of the options along with the surgery. And in the locally advanced hypopharyngeal cancer, there is concurrent CTRT is option along with the nemotuzumab. So nemotuzumab comes into the picture in the locally advanced hypopharyngeal cancer. Next slide. Similar in the management of larynx, locally advanced disease. So there is a need for neoadjuvant chemotherapy and followed by chemoradiation, and also there is an option for concurrent chemoradiation along with the nemotuzumab anti-EGFR. Next slide. So this is the nemotuzumab phase 3 trial by our own Kumar et al. So this is all about the study of effect of nemotuzumab in locally advanced head and neck cancer. The inclusion criteria was more than 18 years of patient, newly diagnosed or treatment naive, stage 3 or stage 4, locally advanced head and neck cancer, non-metastatic, in the oropharynx, larynx, hypopharynx, and the oral cavity with a kind of performance status more or equal to 70% with a adequate organ function. And the exclusion criteria was where the tumor originating from the nasopharynx or salivary gland and the nasal cavity, those patients were excluded from the study. And the patient who had received prior radiotherapy or immunotherapy, they were excluded from the study. It was a randomized control trial. It was randomized to 1:1 arm. The arm A received nemotuzumab, that is the standard dose of 200 mg, along with the cisplatin 30 mg per meter square and the radiation 70 gray over 6 to 7 weeks. And the other arm only received the chemotherapy, that is the cisplatin 30 mg per meter square, along with the conventional radiation therapy 70 gray over 6 to 7 weeks. And primary objective was to see for the progression-free survival, and the secondary endpoint was to see for the disease-free survival, local regional control, overall survival, safety, and the quality of life. So we can see that the 2-year progression-free survival was 50% in the conventional chemoradiation arm, whereas it is 61.9% in the pembrolizumab and chemoradiation arm. So there is definitely an increment of uh, uh, 2-year PFS, and which a good hazard ratio 0.73. So benefit was evident. Next slide. So you can see that the 2-year disease-free survival is 60.2 month in pembrolizumab chemotherapy arm, whereas it is 48.5 month in the chemoradiation arm, which a hazard ratio of 0.71. That is, there is a hazard of decreased the hazard of recurrence by 29% in the nemotuzumab arm. Next slide. Regarding the local regional control, so we can see that the 2-year local regional control was 57.6 months in the chemoradiation arm, whereas it is 67.5% in the nemotuzumab chemoradiation arm, with a good hazard ratio 0.67. So the drug is found to control the disease local regional, so there is good local regional control. And 2-year overall survival data, it is 63.8 month in the nemotuzumab chemoradiation arm, whereas it is 57.7 month in the chemoradiation arm. So it is the patient who had received a cumulative cisplatin dose more or equal to 200 meters square, the impact was similar in the overall result. Next slide. So regarding the management of the oropharyngeal cancer, so early oropharyngeal cancer, definitive RT, one of the option along with the surgery and concurrent CTR. So these are the category 1 recommendation. Locally advanced oropharyngeal cancer, concurrent CTRT, and along with the nemotuzumab. So especially in the P16 negative, which is the HPV negative patient. So mostly the Indian patients are HPV negative. So for that, the nemotuzumab is an indication along with the concurrent chemoradiation. Next slide. So this is based on the Benita Noronha et al. Study. So they have found that the nemotuzumab cisplatin radiation versus cisplatin radiation in the HPV negative oropharyngeal cancer, the subgroup analysis they have found. Next slide. Next slide. Okay, they have found that you can see that regarding the P16 negative, HPV negative category, the 2-year progression-free survival is 31.5 months, whereas it is 57.2 months in the nemotuzumab arm. Whereas as far as the local regional control is concerned, 2-year local regional control is 41.4 months in the chemoradiation arm, whereas it is 60.4 months in the nemotuzumab chemoradiation arm. Regarding the 2-year overall survival data, it is 39 months in chemoradiation arm, whereas it is 57.6 months in the nemotuzumab chemoradiation arm. So you can see that regarding the oropharyngeal cancer, HPV negative, the data is very robust with the addition of the nemotuzumab with a good hazard ratio. So just we have already discussed the median PFS, median local regional control, and overall survival. Regarding the management of the nasopharynx also, so early disease definitive RT is one of the option, and along with induction chemotherapy is also a very good option for locally advanced disease, followed by the chemoradiation. And also the nemotuzumab here is also an indication. So though the Kumar et al. Study did not include the patient in the nasopharynx, but now the consensus has reached that in the nasopharynx also in locally advanced, we can have the option of nemotuzumab along with the concurrent chemoradiation. This is based on, next slide. This is based on the Li Janjan et al. So this is just Chinese data. So they have published the effect of nemotuzumab in combination with the concurrent chemoradiation in patient with advanced nasopharyngeal carcinoma. Next slide. So they have found that compared to the radiotherapy alone, the chemo radiation along with the nemotuzumab increases the response rate. So response rate is found to be higher in case of locally advanced nasopharyngeal cancer. The combination of nemotuzumab decreased the occurrence of erythropenia and neutropenia. So the adverse effects are really not so high when you combine the nemotuzumab along with the radiation. Next slide. To conclude, the nemotuzumab combined with the concurrent chemoradiotherapy is more effective in patients with advanced nasopharyngeal cancer than the chemotherapy alone. The patient receiving the combination chemotherapy did not have a higher rate of adverse reaction. The adverse reactions are found to be numerically higher, but not statistically significant. And nemotuzumab can thus be recommended as an adjuvant therapy in patients with advanced nasopharyngeal cancer. So that was the recommendation from their study. Next slide. Regarding the very advanced disease, so metastatic disease, head and neck cancer, the options are very limited. We can know that there can be an option of palliative RT, or in some very advanced situation, concurrent RT can be an option, but very limited. Palliative RT is one of the options along with the single agent therapy, chemotherapy, along with cetuximab and nemotuzumab. All this can be an option along with the immunotherapy also. So single agent pembrolizumab or nivolumab can be an option. So all this permutation and combination we can do. To conclude, Indian patient profiles are different because we have seen that they are different in terms of genetically, also behaviorally, occupationally, and most of the patient presence is locally advanced stage. So they need more aggressive treatment. And Indian consensus guideline on the management of head and neck cancer are based on the evidence and available treatment options, focusing on the patient need. For locally advanced squamous cell carcinoma of the hypopharynx and larynx, the chemoradiation plus nemotuzumab in these two category have shown significant improvement in terms of progression-free survival and the overall outcome. For HPV negative locally advanced squamous cell carcinoma of the oropharynx, chemoradiation plus nemotuzumab has shown significant overall survival that we have already discussed, and individualization of the treatment remains a key best key outcome. So individualization of all patients are different. So all patients are to be treated individually based on the performance status or the socioeconomic status, and all these factors have to be counted. And definitely we can manage and effectively manage the head and neck cancer along with the use of the anti-EGFR like nemotuzumab. So thank you for from my side, and for any some question, I will be happy to discuss.
Thank you, doctor. It was a very wonderful presentation. You have beautifully highlighted about the role of monoclonal antibodies in treatment. And in fact, tobacco and HPV, these are the two notorious agents causing head and neck cancers. In fact, in one of our national conferences at IAOH and Habitat Center, it was declared that tobacco contains 7,000 chemicals and 69 proven carcinogens actually. So it is really placing a havoc. The smokeless tobacco, chewing, all this is playing a havoc in a patient's life. And promising results with the monoclonal antibodies. We have got plenty of interesting questions, particularly locally advanced thyroid cancers, and plenty of interesting questions are there. We need your suggestion and advice. So we'll have the question and answer session at the end of both the speakers. And now may I take the privilege of inviting Dr. Rajiv Kumar Jain, whom I never miss during all the national conferences. He is very academic oriented and a very dynamic personality. I still remember in one of the IAOH national conferences, he spoke about the creep facilities of Indian Railways. He's a perfect academician. He has done MBBS from MAMC New Delhi, DCH MD, DNP Health Administration, including hospital administration, certificate and diploma in Chinese language, and vice president of IAOH Delhi branch. He is likely to highlight us about the COVID-19 epidemiological updates, because today newspaper says India is the second country which is most affected next to United States. And he is a senior consultant health, Indian Railways, New Delhi. 40 years of experience in health and hospital administration, is a fellow award of the Indian Public Health Association, fellow award of Association of Environmental and Occupational Health, Delhi. He has published and presented more than 145 scientific papers in national, international conferences, journals, and books. Fellowships, scholarships by World Health Organization, National Institute of Health USA, Canadian Society for International Health, and International Clinical Epidemiological Network, and International Society for Priorities in Healthcare. It's a great privilege for us and for all the participants to listen to a great expert. And over to Dr. Rajiv Kumar Jain ji. Over to you, sir.
Thank you, Dr. Kumaran, for saying the nice words about me. I don't know how much I deserve, but all the same, here we are on a Saturday evening, once again, recounting the epidemiological evolution of the pandemic. I would say evolution because as we are gaining experience, the virus is also gaining experience of tackling human beings. And it's maturing as we are maturing. So it's a continuous struggle, and we are still in the middle of the pandemic. Before we proceed further, next slide, please. We would take a view of the World Health Organization, the three best experts in the world, Dr. Tedros, Dr. Maria, and Dr. Soumya, who will give an overview of the current situation of COVID-19 at the global level. Let's listen to them through a video. This video will show you how difficult it is to handle this current pandemic globally, with 194 countries, with diverse backgrounds, with diverse incomes and diverse resources, and how poor countries suffer because they do not have access to vaccines. They do not have means to the knowledge of pandemic management and do not have means to analyze their situation. Even if they analyze, they do not have the means to manage the pandemic. So let's see the video and then proceed further. Shivang, could you play the video?
Sir, yeah, sir, starting in a minute, sir. Can you please brief about the video, sir? I'm starting in a minute, sir.
All right. So this video would highlight the Omicron evolution, that it is not that simple as we thought it was. It is not that mild. It is spreading like wildfire. It is affecting people, even those who are vaccinated. It is also searching for individuals and societies and communities which are unvaccinated or have very little exposure to vaccines. And imagine a substantial population of the developing countries is still unvaccinated. If you see the way the vaccines have been distributed, or the way the capacity for manufacturing vaccines is concentrated in a few countries in the world, and India being so lucky to have its own wherewithal to not only develop but also manufacture, and also has ability to export to the international COVAX facility, wherein in a pool the vaccines are distributed to the developing countries, to the so-called developing countries, but they are an essential global asset. So the vaccines need to reach to the countries which do not have any manufacturing capacity, nor have any access to the vaccines developed by the Western world. So India has come to the rescue of these many countries, and COVAX facility under the World Health Organization is providing a biggest tool to reach the vaccine where it is needed. Let's see the video and understand the situation, the overarching view of the global picture.
We're talking about Omicron today. If it is a less severe variant, why are people still ending up in hospitals, and why is it still killing people? And also, if it is this transmissible, can we really protect ourselves? Hello and welcome to Science in 5. I'm Vismita Gupta-Smith. We are talking to Dr. Maria Van Kerkhove. Welcome, Maria. Maria, let's start with, if Omicron is less severe, Why are people still dying from it?
Hi, Vismita. Thanks for having me again. So Omicron is the latest variant of concern, and we have increasing information that Omicron is less severe than Delta, but it is still a dangerous virus. People who are infected with Omicron have the full spectrum of disease, everything from asymptomatic infection all the way through severe disease and death. What we are learning is that people with underlying condition, people with advanced age, people who are unvaccinated can have a severe form of COVID-19 following infection from Omicron. And so we know that people are still being hospitalized with this variant of concern, Omicron, as well as dying. So it is important that we have information that is out there that is accurate, that does suggest, of course, that it is less severe than Delta, but that does not mean that it is mild.
Maria, we're seeing these reports that because it's so transmissible, eventually everyone might get it. Is that true? And if it is true, then why take protective measures?
We are certainly seeing with Omicron that there is a significant growth advantage compared to other variants of concern. Omicron is overtaking Delta in terms of circulation, and it is very efficiently transmitted between people. It doesn't mean that everybody will eventually get Omicron, but we certainly are seeing high cases and surges of cases around the world. This is putting a significant burden on our healthcare systems, which are already significantly overburdened given that we're entering into the third year of this pandemic. And if people can't receive the proper care that they need, then more people will end up with severe disease and dying. And that's something we want to prevent. So it doesn't necessarily mean that everybody will get Omicron. This is why we, as WHO, are working with partners around the world to have a comprehensive strategy to reduce your exposure and reduce the opportunities for you to get infected. First and foremost, we know that vaccination is incredibly protective against severe disease and death, but it also does prevent some infections and some onward transmission. But it's not perfect in terms of preventing infections and transmission. This is why we also recommend making sure people protect themselves against exposure, physical distancing, wearing of a well-fitted mask over your nose and mouth, making sure that you have clean hands, avoiding crowds, working from home if you can, getting tested, and making sure that you seek appropriate care where needed. All of those measures, this layered approach, are ways in which you can keep yourself safe and also protect yourself from getting infected and passing the virus to somebody else.
Maria, speak to us about why it's important to reduce transmission of Omicron.
It's important that we reduce transmission of Omicron for a number of reasons. First, we want to prevent people from getting infected because there is a risk that you can develop severe disease. There are ways in which we can prevent that, but you are still at a risk of developing disease, and if you have underlying conditions or of an advanced age, if you're not vaccinated, you can develop severe disease. Your risk is higher of developing severe disease. The second reason is that we don't understand completely the impact of post-COVID condition or long COVID. So people who are infected with this virus have a risk of developing longer-term consequences, which we call post-COVID condition. And we really are only beginning to understand this. So there's a lot to learn about this. And your risk of developing post-COVID condition, of course, is dependent on your risk of getting infected in the first place. So we want to prevent that. Third is that getting infected and having a huge case burden, this surge of cases that we are seeing with Omicron, significantly burdens our health systems as well as other essential services that are operating. The large number of cases are really making it difficult for hospitals to operate, for services to be online, public transportation, making sure we have groceries in our grocery store, schools, etc. And lastly, the more this virus circulates, the more opportunities it has to change. So this virus is circulating at an incredibly intense level around the world for a number of reasons. But the more the virus circulates, the more opportunities the virus has to change. Omicron will not be the last variant that you will hear us discuss, and the possibility of future emergence of variants of concern is very real. And more variants that emerge, we don't understand what the properties of those variants may be. Certainly they will be more transmissible because they will need to overtake variants that are currently circulating. They could become more or less severe, but they can also have properties of immune escape. So we want to reduce the risk of future emergence of variants of concern.
Thank you, Maria. That was Science in 5 today. Until next time then, stay safe.
So you heard how difficult it is to understand and how all the more difficult it is to manage the pandemic at the micro level, at the macro level and at the global level. And all the more difficult it is to gather resources on a very long-term basis, on a short-term basis, to be able to understand what we require to move forward. So we move forward to understand the epidemiological situation of COVID-19 as on date. This is a graph which is very instructive. The difference a shot makes. Cases and deaths in second wave versus third wave. And what you are seeing is the pink one is the second wave and the red one is the second wave deaths. And the purple one is the third wave cases and the dark purple is third wave deaths. And look at the difference, stark difference. And why it is so? It is due to the vaccine effect. When the third and second waves are aligned by days since cases bottomed out, we see that Omicron variant has sent case numbers soaring far faster than the second wave. Deaths in the second wave closely followed the case trajectory, something that has not come close to happening this time. You see the flattening of the curve of deaths in the third wave and compare it with the steep rise in deaths and cases, especially the deaths in the second wave. Vaccine coverage in second and third wave is shown on the right. When daily cases were at the same level as today during the second wave, that is the last week of April, only 2% of India's adults were fully vaccinated. Today, nearly 72% are fully vaccinated. On the left, you are seeing the dark blue at the bottom is the fully vaccinated and partially vaccinated are in the light blue. And you see the difference from 2% to 71.8% and from 10% to 22.2%. You see the difference and the effect is visible. The deaths have been saved. Cases, even though they are rising fast, still have not reached the peak of the second wave. Next slide, please. This is where Delhi stands in COVID fight. On the left top yellow one is a cases dip from the fifth wave peak. Today's cases are 16.36% today evening. Today's report has come. Deaths in the past month have been rising. Today's deaths were 45. Positivity rate has come down to 16.36. How it is coming down consistently is visible in this graph. Most beds are vacant. Hospital beds are in light blue and occupied are in dark blue. Out of 15,589 beds available, 2,698 only are occupied on date. Next slide, please. Another good thing that happened with our production capacity, the requirements for conducting the test, the entire infrastructure has reduced the cost of the test. RT-PCR test at a private center is costing only 300 rupees. Price of home collection of an RT-PCR sample is only 500 rupees in Delhi. And imagine the cost of a rapid antigen test in Delhi is only 100 rupees. And in addition, all tests conducted at state-run centers, they continue to be free. So that is the great difference which has come in the last 2 years. Next slide, please. I would now take you to another video where we see a new aspect of COVID-19. Let's watch this video and then move forward. Can we have the video, Shivam?
वैक्सीनेशन अपना लें और हम सब कोविड अनुरूप आचार और व्यवहार को अपनाएं, यही हमारा आपसे अनुरोध है। धन्यवाद।
Yes, we can watch that video. You were playing right, where the health secretary was speaking.
Vaccination.
Now we
know that the overall test performance in the country is being maintained at a level comparable with the second wave.
Make it full screen.
Testing commodities are in plenty, whether it be for RT-PCR, whether it be for rapid antigen test or for home antigen test, or the ancillary equipment like viral transport medium or RNA extraction kits. Then what is important to note that we have noted an increasing uptake of home tests being observed. In the whole of 2021, we saw only 3,000 tests, home tests that were used. And in these 20 days, we have seen 2 lakh home tests which have been used. Few districts and states are witnessing a dip in test performance and have been encouraged to ramp it up. So this is regarding the testing. Regarding vaccines, I have a few points to make. One is that, very beautifully highlighted in that graph, vaccines have remained beneficial in India. And vaccine tracker, which is an online tracker, which gives a week-to-week, shows the benefit of its ability to reduce deaths considerably among vaccinated compared to unvaccinated. So deaths is considerably reduced, and you can see it week by week over the last few months, which is available online in a real-time sense. The current surge in India is not, and I emphasize, is not witnessing an increase in severe illness and deaths following high vaccination uptake. So that was beautifully illustrated in that graph. Because of high vaccination uptake, we are not witnessing that much severe disease and death. However, we have to remember one point: those with comorbidities should monitor their health and avoid complications. So this is regarding vaccination. To summarize, vaccines prevent death and therefore is a must. Having said that, all serious disease and deaths are very low in this wave because of the very high vaccination uptake in the country, which is 94% of first dose in adults and 72% full dose in adults. Thank you.
Yes. So we have seen
Thank you very much.
Director General ICMR showing the evidence and also showing how our behavior has changed. Such a huge number of people are testing themselves at home. That is the confidence that Indian people have shown in our strategy. Let's see the next slide. The slide, please. Slide, yes. Next slide. Yes. So this is a snapshot of India on COVID-19 with confirmed cases on the left, then deaths, then tests per million per day, and the 7-day average test positivity rate percentage and growth of active cases in percentage. If you look at left, the confirmed cases, the top 5 states are Maharashtra, 48,000, Karnataka, 48,000, Kerala, 41,000, Tamil Nadu, 29,000, and Gujarat, 21,000. So dramatically, the situation has changed. Now, southern Indian states are reporting a huge number of cases, especially Karnataka, Kerala, and Tamil Nadu. And Maharashtra continues to be on top. If you look at the deaths, Kerala, Maharashtra, Delhi, West Bengal, and Tamil Nadu continue to be the top 5 states with the highest number of deaths reported in the last 24 hours. Tests per million per day, though they are very high in J&K, Goa, Mizoram, Pondicherry, and Karnataka, but they are very, very low in Nagaland, West Bengal, Andhra Pradesh, Meghalaya, and Madhya Pradesh. If you look at the test positivity rate of India, it is 16.7% in the 7-day average. But look at Pondicherry, 43.2%, Goa, 41.2%, Kerala, 35.3%, and Madhya Pradesh, 34.2%, and Sikkim, 25.7%, Arunachal, 25.4%, Delhi, 24.6%. Large number of states have got test positivity rate during the 7-day average higher than the Indian average of 16.7%. The growth of active cases is very high in the states of Andhra Pradesh, Jammu Kashmir, Arunachal, Manipur, Assam, and Kerala. While the Indian average is 5.9, all these states. Andhra Pradesh 19.57, Jain 19.65, Arunachal 18.15, Manipur 17.23, Assam is also reporting very high. Kerala, Madhya Pradesh, Pondicherry are reporting. Karnataka, Uttarakhand, Gujarat are all reporting very high growth of active cases at the current juncture. Next slide, please. This is the rapid spread in the map of India. You can see Delhi cities with the highest number of weekly COVID cases. Delhi 1,30,000, Thane 41,520, Ahmedabad 31,000, Mumbai 63,000, Pune 72,000, Ernakulam 25,000, Tirunelveli 34,000, Bangalore 1,47,000, Chennai 60,000, and Kolkata 28,597. Look at the way it is spreading east, north, west, and south. All are getting affected. Next slide. Test positivity rate is going up in some of the states, particularly in southern states, while it is going down in others. That is what the graph is showing, which shows the trends in daily test positivity rate and the daily testing in Indian states. Test positivity rate is in red and daily testing is in blue. And all values are 7-day moving averages. Daily testing, however, has declined in some of the states. So there is a cause for concern and also increased need for close monitoring and action on the data that you get and the trends you observe. Next slide, please. This is Southeast Asia region. The number of new cases in the Southeast Asia region continue to increase with over 1.7 million new cases reported, a 145% increase as compared to the previous week. All but one country, that is Timor-Leste, with 58% decrease, reported an increase in the number of new weekly cases, with the largest proportional increases observed in Nepal, with 486% increase, and Bangladesh, 231% increase, and Maldives with 176% increase. The highest number of new cases were reported from India with the 150% increase, and Thailand with 37% increase, and Bangladesh with 232% increase. Look at the numbers in percentage. The trends are alarming. Over 2,500 new weekly deaths were reported, a 12% increase as compared to the previous week. This is Southeast Asia, where India is located. The highest number of new deaths were reported from India with 13% increase, Thailand 5% decrease, and Sri Lanka 8% decrease. And the trend of the pandemic graph is showed in the at the bottom. The entire pandemic graph you were seeing. This is interesting. This shows the districts in the country where test positivity rate during the last 7 days has been more than 10%. So look at the states that are covered. The total number has gone up to 370. 370 districts of India are having weekly test positivity rate, 7-day average test positivity rate more than 10%. But that is not the whole story. There are a number of districts which are showing more than 25%. There are a number of districts that are showing more than 40%. Look at Andaman Nicobar, 21, 20, 31, 21%. Andhra Pradesh, 40.9 in Visakhapatnam. And in same Andhra Pradesh, you have Chittoor, 39.89, and Nellore, 33.58. In Arunachal Pradesh, you have Siang district with 60%, Upper Siang district with 55.56%, and Namsai is 46.7, and Pakis Kesing is 42.86, East Kemang is 41.65. So there is a substantial spread of the infection in the interior of the country. Next slide, please. This is Assam, Bihar, Chandigarh, and Chhattisgarh. And look at the positivity rate in Lakhimpur in Assam, 41.87, Jorhat, 40.21, Kamrup Metro, 37.64, Charandev is 37.53, Sonitpur, 33.5, and Bihar, Patna is 21.49. Chhattisgarh has got Durg, Raigad, Raipur, Korba, all above 20%. Next slide, please. This is Delhi. Delhi, if you see, Southeast Delhi is 31.5, New Delhi is 31.3. New Delhi district includes where the Lutyens Delhi is, where the parliament is located, where the president's house is, Rashtrapati Bhavan is located, 31.39%. Northwest Delhi is 30.53%. Goa, both the districts are showing more than 35%. North Goa 44 and South Goa 37. And remember, Goa is going to under for elections shortly. Gujarat, Vadodara 31.9. Haryana, look at the positivity rates, alarming. Faridabad 47.15. Yamunanagar 41.73. Rohtak 41.59. And Karnal 40.23. The number of districts having more than 25% positivity is very, very high at the moment. Next slide. This is Himachal. Himachal, Lahore and Spiti, 61.97%. The highest in the country is in the remote district of Lahore and Spiti in Himachal Pradesh, 61.97. Kinnaur, 38. Bilaspur, 36. And Kullu, 36. That is the price of tourism and the spread of infection in Himachal Pradesh district, very popular with the tourist crowd. Jammu Kashmir, Jammu has 17 and Badgam has 11. Jharkhand has got 14% and Karnataka, look at the alarming rates in Mysore, Tumkur, Mandya, Hassan and Bangalore rural, all are having more than 25% positivity rates. Next slide, please. This is Kerala. Look at Kerala. The highest is Thiruvananthapuram, 34.38. And you have Thiruvananthapuram is 44.77. Ernakulam is 41.29. Kottayam is 37. And Idukki is 35. Pathamthitta is 35.91. Ladakh is 16.9. Madhya Pradesh, Ujjain 30%. And look at Maharashtra. Maharashtra is so much affected. And look at the positivity rates in Maharashtra. Pune 42% and Nasik 41%, Akola 34% and Wardha 33%. So many districts have got such a high positivity rate during the 7 days. Next slide. This is Manipur, 20% is the highest. Meghalaya is having 16% and Nagaland is also having very high rates. Nagaland is having, just hold on to Nagaland, 45% in Zoneboto. Odisha has got Kohorda district at 33.5. Pondicherry has got, Pondicherry main is 47%. Look at Punjab, 42.63%. Bathinda 37%. Rupnagar 31%. And remember, Punjab is also going for election shortly. Next slide. This is the states of, yes, this is Rajasthan. And Jodhpur is highest with 29%. Sikkim is also 35% in each district. Tamil Nadu, look at the positivity rate. Tenkasi is 49%. Yes, Tenkasi is 49. Krishnagiri is 43. Salem is 40.1. Virudunagar is 33.8. Tanjavur is 29.7. Tiruvallur is 29.63. Chengalpettu is 27.76. Kanyakumari is 27.49. Tirunelveli is 27.53. And then if you look at Chennai is also above 25%. So many districts in Tamil Nadu are at the moment, last 7 days, more than 25% positivity rates. And West Bengal, previous slide, please. Yes, look at West Bengal. Malda 34, 39, Kolkata 39, Birbhum 35, Kalimpong 35, Darjeeling 33, and Uttarakhand again going for election. Nainital is 33. Uttar Pradesh, you see, also you are seeing Gautam Budh Nagar, which is adjoining Delhi, 33%, and also Lucknow, Ghaziabad, Meerut, all are having very high positivity rates, and UP is also going for election shortly. Next slide, please. This is the graph of the pandemic, the global graph of the pandemic. And look at the extreme right. Look at the height of the cases is very, very high, with major contribution by the color green, which is Europe, and the other color is America, which is also shown in yellow. So global contribution of Europe and Americas is substantially high, but positive sign is the deaths have come down. That is the effect of vaccination. Next slide, please. This is the global trend in one table. You see change in new cases in the last 7 days is 20% growth globally, but 68% growth in Eastern Mediterranean, 145% growth in Southeast Asia, 38% increase in Western Pacific, 70% in Americas, and Europe 10% increase. Africa has shown decrease of 27%. But if you look at the deaths, the overall global deaths have increased by 4%, while highest death increase has been in Southeast Asia. Then we have 7% increase in deaths in Americas, 3% increase in Europe, and also 5% increase in Western Pacific. Next slide, please. This is the rank of the countries from top to bottom in terms of cases newly reported in the last 7 days. Globally, 21,52,000 cases were reported, out of which United States itself reported 52,23,000. France reported 22,93,000. India reported 19,83,000. Italy 12,62,000. Argentina 7,81,000. Brazil 7 lakh cases. Spain 7 lakh cases. United Kingdom 6,45,000 cases, and Germany 6,25,000 cases. These are the top countries in the world with cases reported in the last 7 days. Last slide, previous slide. Yes. If you look at the deaths, also the highest deaths are still being reported by USA. Last 24 hours, USA reported 3,000 deaths, and countries like USA, France, Italy, and Brazil, and UK and Germany all have reported more than 1,000 deaths during the past 7 days. Next slide, please. This is the map of the world with shading according to the COVID cases per 1 lakh population reported during the during 7 days. And the highest cases are being reported right from South America to North America to Western Europe, and pockets in Africa and Australia. Next slide, please. This is the map of the world with weekly case COVID deaths per 1 lakh population. The highest, darkest color is still in Eastern Europe and part of Africa. Of course, USA continues to report a good number of deaths. Next slide, please. Let's hear the World Health Organization now. What the top policy-making body of the world has to say about COVID-19 at the current juncture. The video has the Director General of WHO and our Chief Scientist, Dr. Soumya Swaminathan from India, who is working at the moment in World Health Organization, speaking about COVID-19 situation and the analysis of WHO at the current juncture. Could we have the video, please? You would realize how pandemic can get prolonged and can get to make us be alarmed all the time, make us stronger by the day. Also, that's a positive aspect. This webinar itself is a proof that it makes us more resilient, more strong.
To sweep the world. Last week, there were more than 18 million reported cases. The number of deaths remains stable for the moment, but we're concerned about the impact Omicron is having on already exhausted health workers and overburdened health systems. In some countries, cases seem to have peaked, which gives hope that the worst of this latest wave is done with, but no country is out of the woods yet. I remain particularly concerned about many countries that have low vaccination rates. as people are many times more at risk of severe illness and death if they're unvaccinated. Omicron may be less severe, on average, of course, but the narrative that it is mild disease is misleading, hurts the overall response, and costs more lives.
Dr. Kate O'Brien, Director for Immunization Vaccine.
Make no mistake, Omicron is causing hospitalizations and deaths, and even the less severe cases are inundating health facilities. The virus is circulating far too intensely, with many still vulnerable. For many countries, the next few weeks remain really critical for health workers and health systems. I urge everyone to do their best to reduce risk of infection so that you can help take pressure off the system. Now is not the time to give up and wave the white flag. We can still significantly reduce the impact of the current wave by sharing and using health tools effectively and implementing public health and social measures that we know work.
Some actually say, I don't know if it's true, that
Now is not the time to give up on the strategy. We're hearing a lot of people suggest that Omicron is the last variant, that it's over after this. And that is not the case, because this virus is circulating at a very intense level around the world. You will see in our weekly epidemiologic update that will be published in a few hours that there's another 20% increase in cases in the last 7 days, with almost 19 million cases that have been reported to us. And again, that's a true underestimate of what is actually circulating around. And the deaths are holding steady around 45,000 deaths per week. And that shouldn't be happening because we have tools at hand.
In other words, if everyone...
There's no evidence right now that healthy children or healthy adolescents need boosters, no evidence at all. So this is why the SAGE, which is our technical expert body that makes policy recommendations, has been meeting and will continue to meet, will meet later this week to consider the specific question of how should countries think about giving boosters to their populations with a view to protecting people, with a view to reducing deaths.
To check on the latest insights from...
We understand there are a number of species that can be infected with SARS-CoV-2. And then, of course, there's the possibility, we call that a reverse zoonosis. It goes from humans back to animals, and then it's possible for the animals to reinfect humans. That risk remains low. But it is something that we are constantly looking at, because what we don't want, is to have, as this virus circulates, it has the opportunity to infect people as well as animals. And so this is something we need to have better surveillance on, looking at around the world, not only which animals are susceptible, but to track this in animals over time.
Please unmute yourself.
So you've heard how difficult, how vigilance, continuous vigilance is the only way that you could move forward. You heard about reverse evolution, that this virus, while evolving, can go back to new breed of animals or new species of animals and infect the animals once again. Though initially it came from animals to human beings, but it can go back. This slide is showing the map of the world where you are seeing the prevalence of variants of concern, Delta and Omicron in the last 30 days. Delta is in the upper map and Omicron is in the lower map. And look at the way Omicron has spread across the world. The darkest blue color is Omicron in the graph at the bottom. And you are seeing USA, USSR, India, Africa, Latin America, and Australia, and the entire Southeast Asia countries getting very high positivity, how it has become the dominant strain. Europe, Western Europe, you are also seeing the same position. So the eternal vigilance is the only way out. You've got to keep the epidemiology at the forefront, gather data, and base your decision on the data that you have generated and collected. Trust your data. So, in the end, I will say attention is the rarest and purest form of generosity. I am grateful for your generosity because you have given your attention. Thank you so much.
Thank you, Dr. Jain. It was a wonderful presentation, giving statistics at the national level as well as at the global level. And there was a very strong message from the videos that it's nature of the virus to mutate itself. And Omicron variant is not the end of the pandemic. And there is also a risk of reverse. So that is the cautious message we have to take back, and the importance of surveillance, all this case tracking and COVID appropriate behavior. And it's a very comfort message from the Director General of ICMR that even though there is a breakthrough infection in double vaccinated individuals, definitely prevents people landing up in severe critical and mortality rates. And I am immensely happy that the double vaccination percentage coverage is close to 72 to 74%, which is, but still the number could have gone up because it's all because of the hesitancy, vaccine hesitancy. And it's a beautiful presentation, Dr. Jain.
Thank you.
And it was an eye-opener for all of us. Now we'll have the question and answer session. Now let me see if there are any questions from the audience.
Yes, I would like to ask.
Dr. Gajendra has raised his hand.
Yes, please, sir, please.
First of all, I compliment both the speakers for a wonderful presentation on the subject. Now my question is directed to Dr. Rajiv Kumar Jain. See, it is well established a fact that the proximity, and especially without wearing a mask, is the sole cause of spread of the virus. In all the election rallies, we have seen that there is a large number of people not wearing masks and there is a big gathering. So now 5 states in the country are going for election in the next month. So what is your say on the fact that from tomorrow onward, these physical rallies, road shows, jalsas, jalus, everything will be permitted? That is my first question.
Well, very well said. I would say the Election Commission today evening has extended the ban on physical rallies. The chief secretaries of the states that there should be a gap of 3 months following recovery from tested positive individuals, though even though they have been vaccinated, they should delay their precaution dose by at 3 months after recovery. That's the current scientific thinking.
And one more question to Dr. Naba Kalita about the role of HPV vaccine in preventing head and neck cancers. I heard globally there is also HPV vaccine for male population, and one more HPV vaccine 9 has been launched. Your inputs on this, doctor? Dr. Naba Kumar, yes.
Yeah, he's there.
Yes.
Yeah, that's a very valid question. So regarding the role of HPV, we all know that regarding the but the positivity, the prevalence of the HPV virus in Indian population is found to be low. In our parts of the population also, we are doing the HC testing of the head and neck cancer population. So in that population, we are seeing that the prevalence of HPV virus is actually low. And it's a good, actually, good thing to do in the Western countries. They are starting the HPV initiative in Indian population also. So it's a good move, good way of preventing the head and neck cancer. So, but rather than the vaccination, I would urge the people to do the, because the oral cavity cancer is so high in India, and most of the oral cavity cancer mainly acquired cancer, and they can be preventable. It's so regarding the smokeless tobacco, India is the first. The incidence is very high, and India will be among the top two countries, if I'm not wrong. The highest incidence of smokeless tobacco uses is currently from India. So that's a concern for all of us.
And regarding the cost of monoclonal antibodies treatment, doctor.
Yeah, cost is really an issue. So when the treatment of the Indian population is concerned, the cost is one of the factor that always comes to the picture. So the compared to the monoclonal antibody, the nimotuzumab, the cost is almost, if I'm not wrong, the 40 to 50,000 per dose. And so the cost is really an issue, and it's up to the government, the regulatory bodies, the companies, all they can sit together and make a policy so that it can be accessible to even the poorest of the poor in our country. And especially in our state, the government of Assam, from the government of Assam, it has been brought under the government of Assam. So the people, irrespective of their socioeconomic status, irrespective of their income, whether they are from the poor systemic status, are also getting the benefit of this medicine. So that's a really wonderful initiative from the government of Assam. Such kind of initiative can really make the treatment possible even for the poorest of the poor populations.
And is it
But the cost has to
freely
reduce.
available?
Yes, sir. It is nowadays freely available, sir. Yeah.
Okay.
Thank you, doctor. Now a question to Dr. Jain. This is, in fact, COVID is being considered as a inflammatory and thrombotic disorder, actually. Is there any statistics? Because I have seen some of the COVID recovered patients, not on anticoagulants, landing up in cerebrovascular stroke and myocardial infarction or splanchnic vein thrombosis. Is there any statistics about that, doctor?
Well, this phenomenon is a new phenomenon, and we will have to see what is the trend and find out the reasons for the same, whether it is due to overprescription or it is inherent in the disease process itself. Because if you see, antiplatelet drugs and anticoagulants have become a sheet anchor for especially moderate and to severe COVID-19 patients. So we'll have to have a proper study to bring out the results which could ascribe the reasons specifically to COVID-19 treatment or COVID-19 per se. So we'll have to wait for more scientific evidence to come in the months to come. Well, this is an issue, of course, under examination at the moment.
How is the lung involvement in Omicron variant, doctor?
Definitely, it is much lower than Delta, and that's a good sign because its ability to penetrate the cells is much lower, but that is more than compensated with the speed of transmission that Omicron has. So it's able to spread faster, which means that it is able to reach the unvaccinated faster.
And how is the role of fomite transfer as far as this Omicron variant is concerned, sir?
Fomites have a very limited transmission potential in Omicron or COVID-19 per se as well, but we must have more importance to ventilation. Good ventilation is definitely advantageous for reducing not only the quantity, but also the speed of transmission, and also improving the ability of the COVID appropriate behavior to be more effective.
But Dr. Jain, will this high spread of the virus, this Omicron virus, will it not ultimately lead to the herd immunity in the community?
Omicron is only one stage of the evolution. In fact, if we see other RNA viruses, similarly, they have the ability to survive for almost more than a millennium by their innate ability to evolve very fast. As you must have heard Dr. Maria Karkov also talking about it, this is not the last variant. This is one of the variants in its journey towards establishing itself as part of human survival. So it is actually evolving to live with human beings and also affecting human beings in the journey towards evolution. So there will be deaths for vulnerable people, especially older individuals with comorbidities. It's going to strike them because of their vulnerability.
So ultimately the proper wearing of mask remain the gold standard for prevention.
That seems to be the only option in the foreseeable future.
And vaccination, of course.
Absolutely.
Right.
Thank you, Dr. Jain. There is a question from Dr. Gyansham Dulera, Faculty Medical Officer of Schneider Electric, Navi Mumbai. So he is asking when we can expect prevention dose for the 45 to 60 years age group, as the third wave is spreading faster than expected.
Well, a good question for that matter, but as you know, current situation demands two most important priority vaccination groups. That is, one, healthcare workers for precaution dose, second, frontline workers for precaution dose, and individuals more than 60 years having comorbidities. And over that, if you will see for precaution dose, it has been expanded for all the individuals involved in election process. And election will go on till middle of March. So you cannot allow immunization or precaution dose for 45 to 40 to 60, 45 to 60 years of age in the foreseeable future, not before first week of April. That would be the most optimistic estimate.
Okay, thank you, Doctor. There is a question to Dr. Naba Kumar Kalita. Doctor, does gingival granulomatosis, does it land up in malignancy?
Granulomatosis in very few situations. So actually, gingival granulomatosis, we have not seen any patient. So it's very difficult to say, but the prevention then the occurrence of the carcinoma from the gingival granulomatosis, of course, it can, in rare senses, it can happen, but frequency is very, very limited.
And regarding locally advanced thyroid cancers, in head and neck cancers, does thyroid cancer require an extensive follow-up of chemotherapy and radiotherapy, or how do you manage, sir?
Thyroid cancer, the management is something, it is little bit of different from the conventional head and neck cancer, because most of the papillary cancer, so they are the iodine seekers. So the iodine treatment is one of the most important option in the management of thyroid cancer. Of course, the radiation is one of the foremost weapon in the management of the thyroid cancer also. But chemotherapy has very, very limited.
Okay. And as you rightly pointed out, the poor nutritional status of patients getting affected with head and neck cancers, further worsening their quality of life. And of course, it interferes with, because the anatomical nature of the cancer interferes with the good nutritious food intake, actually.
Yeah, we know that the poor albumin status, if the albumin level is low, so it affects the healing also. So after the surgery, along with the poor nutritional status, the drug toxicity, is all these things comes into the picture. So nutritionally, our people are already malnourished, and on the top of it, in head and neck cancer, the people cannot eat actually. So the nutrition is very, very poor, and most of the patient really presents in a very pathetic way. So it's a very sad story, actually, for all over India.
Thank you, doctor. Thank you. Thanks for your. Let me see. The questions are there. And Dr. Jain, is there any change in the vaccination? Is it expected, doctor?
Well, new vaccines will come up, and 2 new vaccines are in the pipeline. The subject expert committee is examining, and I feel that will be the time when we shall open a larger number of people to take. But the problem, as you seeing, if you recollect, the health workers also did not take their schedule of doses of Covishield and Covaxin in time. So they will have to, they are waiting for 9 months to come up, so that good number of people in the first phase of vaccination, the frontline and healthcare workers, they are still in the pipeline to be eligible to receive their precaution dose. So that is a challenge. But India will be, in fact, will be the largest manufacturers of even the range of vaccines and even the volume of vaccines for India itself and for the world. That's what is guaranteed, because there is a whole chain of vaccines under development and very advanced stage of development at the moment in India.
Yes.
So very shortly, you will see a much wider range of vaccines available in the public system.
And regarding the off-label drugs like toxosolimab and remdesivir, WHO has put toxosolimab and remdesivir as the off-label drug. And the latest entry of the antiviral molnupiravir, your advice and expert opinion, doctor.
Well, it's very clear. ICMR had a considered view, and I fully endorse that view, that molnupiravir should not be part of the national protocol, and very restricted use of remdesivir in severe patients and hospitalized patients will be there. But in specific patients having specific indication for administration of remdesivir at the moment.
How is this post-viral fatigue, doctor, in Omicron variants?
Post-viral fatigue we'll have to see, because cases have started coming. People who had moderate Omicron effect, they have just started. The number is not very high, but it is there.
Okay. Thank you, doctors. It was a wonderful session and excellent session on head and neck cancers and COVID-19 epidemiological updates. So much of statistics Dr. Jain has shared, both national level and global level. And national level was really exhaustive, going to the core of district-wise data. I'm immensely benefited, and I think the entire participants and panelists, it was a great academic feast we had today, and thanks for all the thing.
Thank you.
It was a great session, sir.
The recording will be available on the YouTube channel, Enoch DigiConnect YouTube channel shortly, and one could see all the slides and videos over there also and share it in their social media network. Enoch DigiConnect is the webinar platform on YouTube. If you go to YouTube, you just put in ENOCH and you will get the channel where all the previous videos, around 144 videos are already uploaded. This video of today will be the 145th video on that channel, where you can get a diverse range of topics on occupational and environmental health, as well as all the series of epidemiological updates in the past and the current one as well.
Thank you, doctor. It was an excellent knowledge sharing session and an academic feast. Thanks. I feel immensely happy and take pride in being the moderator of this session.
Thank you, Dr. Kumar, to accept our invitation to moderate today's session.
Yes, sir. Thank you, sir.
I wish you good health, actually.
Yeah,
Last
thank
time you were supposed to be moderating, but unfortunately, you
Exactly.
could not.
Thank you. Thank you.
Great to have you today.
Yes, sir. Thank you, sir. So nice of you. And over to IAOH Delhi branch secretariat. Thank you.
Thank you so much.